primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever so relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Maryal Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care is freedom and autonomy. I'm Dr. Rebekah Bernard of Gulf Coast Direct Primary Care, and this is My DPC Story.
Dr. Rebekah Bernard grew up in the rural town of Clewiston, Florida. She attended college at the University of Florida, majoring in sociology while completing her required pre-medical science courses. She was awarded the National Health Service Corps Scholarship to attend the University of Miami, where she graduated in 1999. During her family medicine residency at Florida Hospital in Orlando, Florida, Dr. Bernard was voted Residency Association President by her peers. She also received the program's annual academic award at her graduation in 2002. Following residency, Dr. Bernard completed her National Health Service Corps service obligation in Amok, Florida, at a federally qualified health center. Dr. Bernard continued to serve the community of Amok for an additional 2 years before transitioning to a hospital outpatient medical group, where she worked in private practice for more than 5 years. In 2016, Dr. Bernard opened Gulf Coast Direct Primary Care, a new and growing type of health clinic that provides high-quality primary care for a low monthly fee. Dr. Bernard is the author of 4 books: Imposter Doctors, Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare, co-authored with Dr. Nuran Al-Ajba, How to Be a Rockstar Doctor, and Physician Wellness, The Rockstar Doctor's Guide, co-written with psychologist Stephen Cohen. She is a national speaker on physician wellness and practice management. Dr. Bernard is very interested in encouraging primary care to improve the health of all Americans and improving physician wellness so that doctors can better care for patients. Welcome to the podcast, Dr. Bernard.
Thanks so much for having me.
I just got to see you about a week ago at the Direct Primary Care Summit, and earlier this year at the Take Medicine Back conference, I got to meet you for the first time in person. And I definitely would encourage the listeners out there, if you have interacted with people just as I had interacted with Dr. Bernard over Facebook, and they're, at a conference or they're local to you, definitely reach out or, say, hey, I'm going to be at this conference. Are you going to be there too before? Because it is so awesome to see people in person. And it was so awesome to see you recently.
It is so much fun, isn't it? To actually put the real face to the little tiny Facebook picture and the name. And it's like when you've been talking to someone on social media or other places for a long time and you finally meet in person, it's just like meeting an old friend. So I totally agree with that.
Now, you are in a very amazing position in the direct primary care ecosystem, in that not only do you speak about physician-led care wherever you go, but also you have been open for 8 years. That's incredible. There are, I know a couple of practices in California like that, but in terms of the length of time that you have to reflect on for today's episode, I think that's so invaluable for people to hear from people who are planning to open, to people like yourself who have definitely been seasoned in DPC, given that you opened in 2016. So you grew up in a rural town yourself in Clewiston, and I have practiced in rural America. I live in rural America. So I can relate to you at some level there, but then also you chose to serve the town of Immokalee. So can you tell us what that was like, and why did you choose that versus somewhere else in Florida or anywhere else in the States?
I knew from a very early age that I was really interested in underserved populations and primary care. I grew up, like you said, in a rural area. Both my parents were registered nurses, but my mom got sick when I was about 12. And she was diagnosed with a pretty serious case of bipolar disorder, actually with psychotic features. And that caused her not to be able to work any longer. And it was It was quite a learning experience as a kid, seeing my mom try to navigate the health system in this rural area where she actually had to travel to another county to see physicians. So I had a real heart for that. When I was in college, I had the opportunity to live in Mexico and study and learn Spanish. So I had a real passion and interest in working with Spanish-speaking populations. So when I got accepted to medical school, I applied for a National Health Service Corps scholarship. And it was kind of interesting because when I applied for it, they told me, well, whenever the time comes when you graduate your residency, you'll have so many options to choose. So don't even worry about it. There'll definitely be a place you'll have lots of choices. Well, when the time actually came, there were only 3 sites in the state of Florida for me to choose. And of the 3, Immokalee was the one that was the least challenging logistically because all of those 3 sites were in extremely rural areas, not really places for a single woman, which I was at the time, to really live. So I picked Immokalee because it was about an hour away from a larger city that I could live and commute. And I love the patients, I love the population, but unfortunately, it wasn't the type of place that you could really set up roots, or at least not at the time that I was there. But it was a great experience. I learned so much. Unfortunately, what I also learned was that when you work for a government entity or a corporate entity, you can have the heart to take care of patients. You can have the education, the training, you can show up every day and do your best, but ultimately you are controlled and basically managed by a layer of bureaucracy that often makes it really incredibly challenging to do your job. I found that very frustrating. I found myself very limited in many respects. And so what I love is that, and I of course will get to it, but the fact that I can continue to provide care for underserved patients in my direct primary care practice, including some of the very patients that I took care of in that federally qualified health center. They could still be patients there through their sliding scale or through Medicaid, but they have chosen to pay the low monthly membership fee so that they can come and see me in my practice.
It's just so powerful, and it really speaks to how your patients are invested in the relationship that you have with them. And they might be on Medicaid, Medi-Cal in California for financial reasons or whatever, but it doesn't matter. You can, I mean, clearly, yes, it does in Colorado and Tennessee, but for places like you're in and where I'm in, and most of the country, people with Medicaid and Medi-Cal still choose direct primary care physicians because of that relationship exactly. And it's interesting, I think about your mom, and just that was before the internet. That was before there were resources where somebody could jump on BetterHelp or whatever and do counseling and therapy, or even a psychiatry visit online. But I cannot even, well, it's not that I can't imagine because I was born in 82, but I can't imagine somebody needing access to care, whether that's advice for concerned threat of abortion if they're like bleeding and they're pregnant and they don't know what to do, or if somebody has a mental health concern, what do people do? And nowadays, even though we have the internet, people can't access care because of cost of care, because of lack of internet connection. So it's not too different in terms of how accessibility matters and how lack of accessibility really affects a patient. So I love that you did what was right for you in terms of where you chose to practice, but now because of the doctor you are, your patients have even followed you from Immokalee. It's so awesome.
Well, one of the things that I just want to say about what I went through with my mom and watching her is that even though she traveled to another county, she was ultimately able to access the right quality of healthcare. She was able to actually see a real psychiatrist and a real psychologist. And my concern, as I'm sure we'll get into, is that sometimes when we open up and we say we want more access, we need to really be cautious to make sure that the access is to the right people. I would rather have had my mom get transportation and go a county over and see a physician who had the training than have her potentially go on an internet or do a phone consult with somebody that maybe doesn't have the experience or training to give her the right quality of care. So I think it's so essential that we're always balancing that. And that's one of the beauties of direct primary care, is that we can provide physician-led care, but we can do that in through so many ways, whether it's face-to-face, video, phone, and it's just so versatile. And so tempering access with quality, though, is a caveat that I'll come back to over and over again in these discussions.
And it is a caveat that needs to be addressed at every level. I mean, just recently, I think it was today, you posted about how a non-physician provider was being looked to as an expert on a media channel. And it was like, okay, like there are doctors who also speak to the same things. So I think that it is very relevant to our discussion, especially given that places like California, people who have been listening to the podcast are very aware that my husband lost his job because the corporation went to a non-physician model. So patients don't even have access to a physician. And so I totally echo what you're saying. And I'm sure that there are people in the audience just vigorously nodding their head or shaking their head in frustration with our current system. So let me ask you there, when you said, hey, I loved my time at Amok, did my service, chose to then go into private practice. How was that transition, and what was the private practice experience like, given that that was what you had in your medical journey between Amok and direct primary care?
Well, it's funny because sometimes I like to say that I went over to the dark side because I went from this sort of, I'm going to help the underserved and work for the patients with the most challenges socioeconomically. And now here I found myself accepting a job at a for-profit hospital system. And I did that because I had this idea in my head that maybe I just needed to see how the other side worked. Maybe the problems, the frustrations that I felt in the clinic I worked had to do with the fact that it was a government type run. It wasn't really a government run, but government funded clinic. And I thought maybe it's better on the other side. Let me see. What happened was a very rude awakening in which I learned that even though it's funny, the counties that I worked at, Immokalee is in Collier County, and so is Naples, Florida, which is a place that has some of the most concentrated wealth in the United States. And in fact, Collier County is a county that has the greatest separation between the richest and the poorest residents. So I went from the poorest to the richest, or the most affluent patients, and yet I found myself facing the exact same frustrations and challenges every day. I had thought that the frustrations that I felt had to do with the patients, like not being able to get them medications or to see a specialist. But now that I was in a new place where I could send patients all over, in fact, I called it it was like a ping pong table where, what are those games that you play with the jukebox, where, not a jukebox, pinball. It was like a pinball machine. I would send my patients to a specialist, and then that specialist would send them to 4 other specialists. So they certainly got more than enough access to care there. And yet I found myself frustrated with, again, I would ask, could I do things slightly differently because it would be more efficient? Or could I adjust my schedule that way? And the answer was always no, that's not how we do things here. And so once again, I found myself incredibly frustrated. Here I am as a physician trained to be a problem solver, and I'm completely stymied. I'm basically told, you're just a cog in the wheel, show up, see your patients, and be quiet. And that's just the kind of attitude that I think for a lot of us is really hard to swallow. In fact, after doing that for several years, I was getting more and more frustrated. And I remember it was Doctor's Day, and our hospital had been acquired by a larger health system, in fact, the largest for-profit system in the US at the time. And they came for Doctor's Day. They gave us, usually they would give us some Danishes. So that day they had put out some eggs and things like that. And at the meeting, they introduced the new corporate people. They were all in their suits and ties. And they stood up and they said, oh, and by the way, as part of our transition, we will be going to a brand new electronic health record, and there will be no data migration. The doctors will just be responsible for archiving their patient records from the old system to the new system, but we're going to give you some RVU credits and et cetera, et cetera. And as they were talking, all the doctors are looking around at each other like, what? This is insane. We have patients that have years and years of medical records. They're very complicated. And we were murmuring and people were raising their hand. And I remember one of the new CEOs looked at the other and looked at us and said, I don't understand what you guys are complaining about. We gave you a free breakfast. And I remember just like you just realize that they didn't get it. They didn't care. And as I left that meeting, I texted my friend who's a doctor also at the meeting who worked for the company. And I said, I'm out. I'm going to look for a new job. And I cannot do this for another second, especially because I had put so much of my time into trying to fix this very broken electronic health system. I was on the volunteer committee to try to make it better. And then for them just to say, we're going to a new system, it felt like everything I had done, all the work I had put in was for nothing. So it was at that point that I decided to start looking around for a job. I found an urgent care that was looking to have a primary care physician in the practice, and I accepted a job there. I took a little bit of a pay cut, but I thought it would be a better situation. And it actually was. I really enjoyed it until they started having some financial trouble, and they would let the electric go out because they wouldn't pay the electric bill. They'd have to call and get it turned back on. Then the fax machines weren't working and so the final straw was that they stopped paying for our health insurance. And one day I got an earplug stuck in my ear, and I had to go to the ENT next door and get help to get it out. And I said, I'm sorry, I don't have any insurance. I'll just have to pay you cash. And at that moment, I realized, okay, it was just an earplug, but what if it was my appendix? And so I did the thing that really is never a good idea, which is to go into a meeting very fired up and frustrated and angry. I'd had multiple conversations and texts and emails with the boss. And I went in and I just said, if you guys don't fix this, I'm going to give you my notice. And fully expecting that, of course, they're going to fix it. I mean, I was very productive. We made them a lot of money at the practice. But then the next day, I went into work and they were waiting for me and they said, pack your things, you're fired. And so that was actually the best thing that ever could have happened to me, because from that moment, I realized that it was time for me to own myself. And that was when I started my direct primary care practice.
I just think about how you're right, especially in the end there where you're like, I just realized I gotta look out for me. If I am not taking care of myself, I cannot take care of other people. That the whole sentiment really comes through when we transition to DPC and we recognize like how terrible fill in the blank was. The lack of time I could spend with family, the lack of ability to go on vacation, the lack of ability to control my schedule. It's literally a fill in the blank thing that we experience at different levels. And I just think that that is something when you share about how the urgent care was like, we don't care. We don't even care about our electricity for patients. I think it's a gift for people to hear your story, especially the younger audience, the people and not necessarily younger by age, but younger in medical journey in terms of medical students and residents, because it's like listening to this podcast is like a crib sheet of you could spend 8 years doing this, or you could just do DPC right out of residency or even during residency. So I love this. Now, tell us about your transition to DPC, because you gave one of your very first talks about DPC the year you opened to the local residency. And so it's like, man, you came out of the gate fired up and spreading the gospel of DPC, which is amazing. You continue to do that to this day. But how was that transition like, especially for you to be able to say, yeah, I just opened and I'm telling residents about it already?
Well, I'll tell you, the reason I was able to do it so quickly is because some years before, I was just kind of scrolling along this physician social media site called Sermo. It's still around. I don't really go on there too much, but at the time, I don't think there was a lot of other social media that I was very active on. So I would go on there and I would read. And there was this guy named Lee Gross. Of course, we all know who Lee Gross is now, but at the time, it was just this Lee Gross. And he was talking about this epiphany that he had had and the idea of direct primary care. Of course, you may know his practice is called Epiphany Health. And he just happens to be a few counties north of me. And he was posting and writing about this transition. I think he shared a story of when he got a check from an insurance company for 2 cents or something like that, and just had enough and decided to open this practice. And so every time he would post, I would just read everything he wrote, look at people's comments and discussions about it. And I kind of fantasized, wow, I would love to do that. What would that look like? And what would my practice be called? And how would I lay out my rooms? And I just kind of let my mind go on that. But I was not brave enough to actually do it myself. So that's why I like to say that as much as I was pretty shocked and hurt to get fired, it turned out to be the best thing because I don't know how long it would have taken me, if ever, to have actually had the courage to strike out on my own. However, having had the benefit of having read all of that information and just let my mind do that thought experiment, when the time came, I was able to go from being fired and not being able to tell my patients where I was going or easily transition them to open up my practice within just 3 weeks. And actually, I think it's next week that I'm going to have my 8th anniversary. So it's really exciting because I remember saying to myself, if it doesn't work, then what's the worst that can happen? So I said, I'm going to give it 1 year. At 1 year, if I'm happy, if it's successful, we'll keep going and we'll take it day by day. But if at 1 year it's not going well, if I'm not happy, if I'm not making enough money to sustain myself, I mean, come on, I'm a woman primary care doctor in an area that everywhere is underserved for primary care. I can get a job working for someone anytime. So that 1 year mark was really important, of course, because at that point, in fact, I was able to grow really quite quickly, even though I wasn't able to tell my patients where I was going. And believe me, the urgent care was not forthcoming. When people would ask where I was, they would be like, I don't know, she just left. And I think a lot of people actually it was kind of emotional because there were people that thought the best of me and assumed that that couldn't be true. But there were an awful lot of people that were very quick to assume that I had done something wrong, that I had got myself fired by some kind of bad behavior, or that I had just abandoned them, that I just didn't care. And it was really hurtful to realize that. And that those kind of feelings also came from staff members because I wasn't the only one that got fired. They let go of my entire team that worked with me. So there was a lot of emotions and hurt feelings over that I had to overcome. However, even though patients weren't given a lot of clues about where I was, we do live in a world where you have things like Google. And so immediately I put my name, I created a website, I put myself on Google, I changed my address with the Board of Medicine. I did all the things that you will read about what to do when you're starting a DPC practice. Claim social media pages, get your address changed all over the place, even though to this day, 8 years later, I still find my old address on some of these like health grades and vitals, and even some specialists are still sending me stuff to a really old address. But you do your best to change all of that information. And so patients were able to find me. And I knew that I needed 100 patients to pay my overhead. I'm a big believer in low overhead, and I knew from the beginning that that was going to be important. So I needed 100 patients, and within a month, I had 100 patients. And I would say by a little after, maybe about a year and a few months, my practice was full with about 600 patients.
It's incredible. And I just think about when you talked about how just demeaning, devaluing, demoralizing, all of the things were that you and your staff experienced, and that it was like, yeah, that's great. You're the ones who actually see the patients and you're the ones who bring in the money, but we don't actually care. And you can go on to the next thing. We don't really care about you. I think about how people have said on this podcast, DPC is definitely work, but it's definitely different work because you don't feel that devaluement at every turn.
Right.
And I think that is what really keeps the wind in our sails, and why people like yourself have gone on next week, or you're almost at your 8th anniversary. And I misspoke earlier, but that's freaking incredible. So it's awesome. And I think that this is also why we do see medical students and residents recognizing the just complete deflated people that they interact with in these corporate models of medicine. And they Google different terms, they look for different ways to do medicine. And that's how a lot of them are coming to DPC now, which is very cool. So let me ask you there, because as you said 3 weeks, like, oh my gosh, that made me cringe, just because my transition was definitely more calculated. I knew I was going to leave before I handed in my email. But when you went from, man, I got to open and opening days in 3 weeks, what did you do during that time?
I didn't know we were going to be able to get it done in 3 weeks. I just knew I wanted to be open as soon as possible because I knew that my patients were going to need me. I probably had a panel of 3,000 or so, just like every primary care doctor has. And I knew at a certain point they were going to need refills, they were going to need follow up. And so I wanted them to have access to me if they chose to have access to me. And I had this sort of idea that the quicker I could get them converted over back to me, the better it would be for my practice, but also for my patients to have that continuity. So the first thing that I did was I decided from the start that I needed to have a right-hand person. And I know that there are a lot of DPC practices that operate as a micro practice and the physician does it all. I'm not one of those, and I never could be because I just value my time off and not being tied to the practice. And I also, there's a lot of things about running a practice that I don't want to do. So I knew from the beginning that I had to have a right-hand person. So I brought my office manager. She was the only one of my staff members, even though they were all great, but I knew that I didn't have the budget to bring very many. So I selected the office manager, even though she didn't really have the clinical skills. She had very strong clerical skills, and I knew that I could do all of the clinical aspects myself, but where I would want to have that support is on the clerical part. And also that's the part that is not as much fun for me. So I engaged her right away as she agreed to come work with me. And then she and I, as a team, we just got right to work trying to figure out the fundamentals. Number one, where are we going to work? So I think your location is really critical, of course, especially when you're looking at your overhead. So our job, what we decided was, let's find the cheapest rent that we could find within a reasonable location. We wanted to stay in the area where our urgent care location was. I didn't have any no compete, fortunately, except for to not work for a competing urgent care. But the rents in that area were just pretty steep. So we looked a few miles south and we found an older building, and they had executive suites, which included things like electricity and water, and the price was right. In fact, they gave us a free first month, and then it was $1,000 a month. It wasn't ideal because we had two rooms, but they weren't adjoining. They were kind of catty corner to each other, but it was fine. We said we're going to make the best of it. It also didn't have a bathroom, even though it was zoned medical. So we had to have our patients use like a shared restroom. And then later I did end up getting some portable sinks, which worked out really nicely. But the idea was just, what's the cheapest rent? Because again, remember, this was sort of a thought experiment that I had, which is, how do I do this in 1 year? So, or how can I get it done as fast as possible and be successful in a year? So then the next thing was getting equipment. I went right on Craigslist. I bought an EKG machine. I like to joke that it's almost as old as I am. So it was about 40 years old when I got it. It's older now, but it's still the best EKG machine I've ever owned. And I got all my different equipment, either begged, borrowed, or steal, or got really, really cheap off of Craigslist. Started setting up accounts for medicines. And again, this is where I had that office manager to do a lot of that work for me. So while she was doing that, then I actually went out into my community. I went to as many places as I thought was reasonable to that they would see me. I walked into pharmacies. I went into specialist offices. I talked to as many people as possible just to get the word out about what I was doing. And at the time, I think I was the first DPC practice right in my community. Lee Gross is in Charlotte County, but in Fort Myers, Lee County, I was the first one doing it. So a lot of education about what the model is. I was really lucky that a local journalist did write an article based on a press release that I sent. And so that was really helpful to kind of explain the model and get patients in the door. So it's amazing how much you can get done in a few weeks if you sort of have a checklist and you have someone to help you and you just put your feet on the pavement and just go for it.
I completely echo that. If listeners, especially if they're new to the podcast and they don't know, I was with a letter that said, you're going to be fired if you don't do X, Y, and Z. And I was 28 weeks pregnant when I started this podcast. Literally 2:45 in the morning, I woke up, so all of the feelings, sad, angry, devastated, like all the things, sat on the floor, never had done a podcast before, only listened to them. And by the time my husband woke up, had this podcast, logo, website, podcast feed, intro recorded. My husband's, well, good morning. And this is, so I echo that. If you are fueled with, I'm not going to give up and I can't do that again, you are capable of a lot of things. you're a freaking physician. So you are smart and you are able to do hard things. So I love, love, love that that was your transition and you just did it, right?
And it's not that hard. I mean, it's not rocket science. I would have been a lot more daunted had I been trying to open a traditional insurance type practice, because then I'd have to get contracts and I have to wait on other people. With DPC, really, the ball is in your court and you just can start going. You don't have to wait on anybody. You just get going.
And especially now with non-competes being the argument that they are not enforceable, period. And yes, there are people fighting that, but this is a great time to be doing DPC because there's less fear out there of those non-competes. And I just wanted to say a couple of things. I love that you talk about the overhead, especially with the executive suite and the bathroom being in a separate area. Dr. Krista Springston, her first clinic was in an executive suite. She shared about that in her podcast episode. And Dr. Leah Gupta, her clinic is the same in regards to the bathroom is in the hallway. When I visited her clinic in Hinsdale, you could see how great this is, just how it is. Like, your patients would rather walk down the hall to the bathroom than go to a fee-for-service clinic. That is not debatable. So it's okay if you have a space and you're looking at it and you're like, this might not be my forever space, but it does have things, I can afford it, and I can open with a quick lease, a short lease. Great. But hear Dr. Bernard's story, what she's saying, because the relationship is what a patient is going for. Dr. Michelle Little, I remember her saying, during the pandemic, she was like doctoring in a parking lot with a chuck on the car. So literally that should not be a fear for people. I opened without a physical space. So it's possible to do DBC in different ways.
Yeah,
So
and I think patients actually like it too, because you have an idea in your mind when you go into a medical space that it's going to be, you're going to smell antiseptic and it's going to be a little bit scary. And and then they walk into a place like mine and it's maybe a little shabby chic, but they're like, oh, it's so homey in here. And I think it makes people feel very comfortable and very relaxed. And it's not for everyone. There are people that want that antiseptic smell and they can find that, just not at my office.
You mentioned how your patients from Immokalee came and you grew to a point where, again, you went on into the second year. Was word of mouth from those community contacts the way that people from Immokalee and all of your other patients really found your practice?
Yeah, number one is definitely word of mouth. And I think you'll hear that from many DPC practices, as those are usually the best ways to get patients. And there's no greater compliment than when a patient encourages their friends or family members to come to see you. The second way that we got quite a lot of patients was through the use of social media. Now, one of the things that I learned fairly early on that I counsel people when they ask me is that spending a lot of money on advertising for DPC, I didn't find it to be very effective, and most people I talk to don't have a real positive experience. What you learn when you first open a practice, all of a sudden a lot of salespeople start coming out of the woodwork, and they're very good. I fell for it several times. They will tell you like, oh, this is such a great practice, I'm going to sign up as a patient. By the way, they never do. And then when you buy the ad in the newspaper or the local flyer, then and you don't get any patients, they say, well, that's because you have to let it go a couple months. People have to see it multiple times. And so they always have a really good answer. And it may very well work for some things, but for me, it was not really a very great use of money. I found the best advertising outside of word of mouth was simply to create a presence on social media. For me, it was Facebook. I think there are others that people use, but that worked very well for me. What people seem to really like a lot were little videos, just short ones where I just talked about the practice. I maybe did a little tour of my office. I showed my office manager. I think people are looking for that relationship and they want to feel that they know their doctor a little bit. So I think that that those things resonated with them, or sometimes a little educational clip. And I did pay a little bit of money to first boost my page to get more recognition of it, because that then made the posts become more organically spread. And I did spend a little bit of money here and there on boosting individual posts where I would say maybe free registration for the next 100 people or whatever, things like that. And I would usually just spend $20 or $30, not a lot of money. The other thing that's very helpful on social media is to find those community groups, and especially if they have a open day that you can post your own business, or even better, if someone is asking, hey, does anybody know a good doctor? Then even best if you can get a patient to write about you, but you can even talk about yourself in those places. So those were some really effective ways that we were able to grow our practice in the early days.
That's fantastic. And I think about even strategically putting your boosted ad or whatnot in a particular zip code, that can also help really maximize your reach, especially if you're not going to be practicing in the area where you're currently at. If you're moving to a different state, you can literally still target the zip code that you're going to be practicing in, as well as if you are staying in the same location, you can use that too. So just it's great that for a very small investment and very affordable, you can track the data, see like I did this is the type of post I boosted, and this is the result that I got out of it. And definitely if you are not, or if you have not thought about it, try to capture your lead source. Like, where did your patients find you? Did they hear from word of mouth? Did they hear from social media? And you can even use different trackable links on different platforms to collect that data without even getting that answer directly from a person. So lots of ways to do DPC, lots of ways to get the word out about your practice. Now, as we continue, I just want to give the listeners a little bit of geography, because you are like, Florida's big. Florida's like California. I had to look up where is Fort Myers. So you are on the western coast of the state. Can you give us some demographics about your patient population in particular, given that you are a person who loved to be a quality, accessible physician to her patients, no matter what socioeconomic status they come from?
Yeah, I'm on the Gulf Coast of Florida. I am just 2 hours south of Tampa, and directly across the state if you go on Alligator Alley from Fort Lauderdale. So it's a really interesting place because just south of us, we have, I mentioned Naples, Collier County, which also has a big difference in patient population. You've got some very blue collar and even low income patients. But this is also the place where we have a lot of concentrated wealth, especially as you get down into Marco Island and Port Royal. At the last count that I heard, there were over 70 concierge physicians in Naples serving that area. And it is not a large town, but that is just speaks to the concentrated wealth. Now, I don't live and work in Naples. I live and work in Fort Myers, which is much more of a typical town, much more of a blue collar town, which I really like. Those are kind of salt of the earth people I relate to. My parents were both nurses. And I always say I grew up in a trailer, and you can take the girl out of the trailer, but you can't take the trailer out of the girl. So I relate very nicely to the Fort Myers community. And not to say that Fort Myers doesn't have its upper end and things like that, but it's not like Naples. But actually, it's worked really well for me here in Florida because our state is one of the states that did not accept Medicaid expansion. And so what happens is that we have some patients that are quite indigent and qualify for Medicaid, but much less than in certain states because we didn't expand. And because the cost of health insurance premiums, even though everyone can theoretically get health insurance through healthcare.gov, through Obamacare, the premiums are really quite high. We really do not have a lot of competition. I believe in my county, when I last looked, there was only one insurance carrier. And so when I looked for myself, it was over $2,000 a month for a policy for myself and my husband at the very highest limit of deductible. And I think the out of pocket was like $14,000 for $2,000 a month for a plan I'm not going to hopefully ever use unless something catastrophic happens. So if that's happening to me, imagine all the other small business owners in our community. And we have so many, lots of construction people, roofers, tilers, cleaning people. They're all stuck in that exact same situation where they don't qualify for Medicaid. They're hardworking people, but they earn too much for subsidies, or even with subsidies, they cannot afford traditional health insurance, or they have to buy a high deductible policy. So essentially, coming to your primary care doctor is not going to be covered unless it's one of those few, like your once a year annual visit, let's say. So that is actually a perfect environment for direct primary care, because that is a large patient population that needs quality health care, that has all the typical primary care conditions that are our bread and butter. And fortunately, I love managing. I love basic hypertension, diabetes, hyperlipidemia, anxiety. That's what I do. That's what I like. I love doing screening and wellness. And so my patient area is really perfect for DPC. The other thing, while I'm speaking of anxiety, I don't want to forget to mention one of the things that I did early on, probably just not even a year in. I realized that so many patient issues relate to anxiety. And hey, I have it too. I get it. So anxiety, and then of course, if you have a chronic illness or a condition, then that takes a psychological toll. So I decided that I really wanted to bring in an in-house psychologist. And so I found someone on Indeed. I put an ad on Indeed, and I was really surprised at how many responses I got. I just put on there, I wanted a psychologist, but I was open to other types of therapists. I said, I'm looking for someone just 1 day a week. The pay is not going to be like a huge amount of money, but the job is going to be pretty straightforward in that you don't have to do billing, you don't have to do extensive notes, you just basically take care of patients and write what you need to write. And I found an amazing psychologist who joined me, and she's actually been with me now for 7 years. When we first started, we charged the patients $60 a session with her. That's basically a pass-through. I just collect the money and pay her directly. Now we've raised that to $75 a session, just, because it's been some years. And I have to tell you that not only is that amazing for patients, but it is, as a physician, having an in-house therapist so that you can refer your patients when, they need that level of care, and you don't have the time, the energy, or the tools to give them the psychological treatment that they need, the cognitive therapy. Having that in-house therapist is something that I wish every primary care physician would look into and try to find a way to incorporate that.
Absolutely. And so pertinent. Just your interview is coming on the heels of Dr. Jeffrey Schuckman in Woodland Hills, California, who spoke about how he brings people into his clinic. White Olive DPC uses relationships with different providers in terms of like people who do aesthetics, people who do therapy, and the patients just contact with them directly. It still brings not only an affordable option, but a credible option, especially if you're handpicking the people who come to your clinic and who are going to interact with your patients. And when you said 60 and then you raised it to, and then you said 75, I was like, seriously? To see a psychologist is like $180 a session, and maybe insurance will pay for 4 to 6 sessions. So that's a huge steal. My question with saying that is, what difference did you see in your patients, given that you lowered the access to quality mental health care at your practice?
Absolutely incredible. I've seen patients change their lives for the better because of the work that they've been able to do with the psychologist. And I give the psychologist all the credit, although she says for me to give myself some credit for creating the space. So, okay, I'll accept that. But it is so remarkable. I remember we had this young man, and when he came in, he was so shy. He could barely look up. He was living with his grandmother. He had this crippling anxiety. And after a few months, he moved out from his grandmother. He got engaged. He ended up moving, but for good reason. He got a job. And just seeing that, it almost brings tears to my eyes to think that this is somebody that maybe, had he not had that intervention, I mean, who knows what would be happening. And of course, not everybody has those tremendous breakthroughs, but I think a lot of people get benefit, even if they just have a session or two that helps them to think about something a little more clearly, or makes them realize they're not crazy, or they're not alone, or that their feelings are valid. I think it's just so empowering. And then it's also really empowering for me if a patient's over and over again, the same issues, and you're just not moving and you're starting to get frustrated, to have that touch point where you can have them see. I always say, like, I encourage, I ask, I beg, I plead, and sometimes I have to insist because sometimes I just realize that patients are just really stuck. And so I try to get them to go. And even if it's just for me to talk to the psychologist, because I like to talk with her and kind of get debriefed about what she learned. And she often tells me things that I didn't realize. But sometimes it's just for her to say to me, no, you're not wrong. This person they're just stuck, and we just have to continue to support them and encourage them until they're ready to make change. And that can be very validating and helpful. And it's another reason why DPC is so freeing, because those are the types of patients, if you work in the traditional system, you're getting dinged on your reviews. You're getting X marks because your patients are still smoking, or they're still doing whatever habits you don't have control over. And so in DPC, we're able to continue to support those patients in the hopes that, and sometimes when you least expect it, they are finally ready to make change, and you do see them improve their health.
Absolutely. I think that I do agree with the psychologist, and that, like, your being their doctor also plays a massive role, just because mental health is health and physical health is health, and you guys are both playing roles in your patients' lives. I think that that is something that a lot of the listeners are probably shaking their heads at, in terms of the differences in quality of care, where you have a physician and you have a patient, and that's it. And it's interesting because, like, I think about the diagnosis code for smoking, ICD-10, I don't know what it is, don't care, but just the diagnosis of smoking, it's, yeah, but they were smoking 8 packs a day and now they're smoking 2 cigarettes a day. Like, the code is still the same, but you've impacted their life. Clearly, a lot of it is patient driven, but in terms of, like, your role in helping a person get one step forward on that path of change, and it's not going to be everyone fine, but it's like, for the people who it is for, it's incredible. That's why you get these endless stories of people like, oh my God, I have this one patient, I have this one patient. And I just love when we see little changes, big changes, all of the things, and you're able to just do that. Like you said, you're just able to have the time. If one person has a death in their family and they need a little bit more come and go care rather than see the big breaks between visits, you can do that, and you can craft your clinic to respond to what your patients need.
Right. Exactly. That's the beauty of it.
So you are, as I mentioned, a massive advocate, as we all should be, for physician-led care, in terms of, you speak not only about direct primary care as a model for people to establish a physician-led practice, have a relationship with their patients, but you are also very active on the national scene at many levels. So could you tell us about the roles that you have played, the avenues of advocacy that you have been down and you continue to go down, from the AMA to your state medical association to, again, even the residency local to you?
Yeah, I think one of the most valuable aspects of DPC for me is that it has given me the freedom and the time to get involved with organized medicine. I'm a big believer in grassroots medicine, and I'm the co-founder of Physicians for Patient Protection with some other physicians, which we've worked very hard to get some of our national organizations more aggressive about moving the needle on physician-led care. And I think grassroots is critical, but I think also we need to be at the seat in organized medicine, because when we show up, we can influence change. And I've actually seen it happen where I've watched a person stand up at a microphone at, for example, my state House of Delegates meeting, say something about physician-led care or direct care or something to that effect, and watch the different physicians like really listen and hear it resonate, or hear them say, is that really an issue? And then I've seen the next year where now multiple people are talking about it. And the year after, there's now an active force to work on what that one physician brought to other doctors. So I think a lot of times we get a little discouraged. We feel like we're like the lone voice crying in the wilderness, but that's actually only the case if we're not trying to engage with our fellow physicians. So I take that as a personal responsibility, even though it is frustrating and trying and does take time. But the reason I do it is because I feel called to do it, but also because I can do it. And I recognize that a lot of people that are working for a corporation or an organization, they're not free to speak freely, because if they say something, they could be fired and they may not be able to support their families. Because I own myself, I can say whatever I want. As long as I'm not getting myself in trouble with the Board of Medicine, which I wouldn't, then I am free to speak the truth. And I also have the time. So if I want to go up to an AMA meeting that unfortunately is quite a few days away from the practice, and I get why a lot of doctors can't do that, because when you're not seeing patients, you're not making money. But because of the DPC model with our membership practice, I can take time away from the office without it affecting my bottom line. I can still be available for my patients virtually, or in my case, recently, I hired another physician to cover the practice because I found myself getting more involved with different organizations, and I wanted to be able to give my full attention to that when I was away. So I really encourage every listener out there, if you feel called to work on a particular topic, something that touches your heart. For me, it's physician-led care, in part because I think part of it's being a woman in medicine and realizing the hurdles and the efforts that it took to get to that place, and also having a deep understanding that there was a reason that we went through that suffering. There's a reason that we delayed our fertility. There's a reason we made a lot of really hard choices. We chose not to take shortcuts, even when articles were being written saying women doctors would be better off becoming a PA because they would end up making more money because of time off and less school and less debt. And we're hearing all this messaging, but actually it's very valuable to go through that, because that's what you need to do to give patients the best care. And it hurts my heart when I hear someone say, but do you really need to do all of that? You could just do an online program in 500 hours and you could be just as good. And they'll claim that studies show that. And that's not what the studies show at all. So I'm a big believer of team-based care. I think that NPs and PAs work really well with physicians. Patients can get great results, but that there's no data to show that's the case when physicians are not involved. And I don't think it's arrogant or elitist to simply say that physician-led care is the best care, because it is you just take the longest to learn your practice and to learn how to do it. So I am super passionate about it. In the DPC space, I am concerned that I am seeing a lot of non-physicians hang a shingle and open a DPC practice. I fear for the model, because I think that we're going to have, and we do have, scrutiny from the powers that be on what we're doing. And I think that it's important that we hold our model to the highest standards, that we practice evidence-based medicine whenever we can, knowing that that's not always possible, and that we ensure that only people who are properly trained and qualified to practice medicine are the ones that are doing it independently, and that is the physician.
One of the things that I thought when you were speaking just now was how, like, we learn from attendings. I have been in a place in the Dominican Republic where second-year resident was teaching first-year resident how to do a tubal. And I'm like, you don't do a tubal by tying the fallopian tubes like a shoestring. You just don't. Like, I don't know how, but I'm assuming that it's because they had bad modeling, that just trickles down. And I say that because I think about, I used to do colonoscopies. I got pushed out of doing colonoscopies, but like, where is a family doctor going to go to learn colonoscopies? The art is lost if you don't have people to model what you're doing, what you can do, what you're wanting to do. And so I do agree with you also in that direct primary care. I mean, and probably everyone on this podcast knows this, I love talking about DPC anywhere and everywhere I can, just same as you. And that is so true. When you get to be your own boss, I love that you said you own you. Like that is great. But you get to say, I want this size of practice because this allows me to, again, fill in the blank, do whatever you want to do. That I think really brings a lot of one's personality out. Like, people do walk with a doc, they go and they do musical theater. Like, people do all of these things that we didn't have the time to do before. You just freaking went to Egypt, right? Yeah. So
I've been to Africa a few times this year because I love traveling too. So exactly. So you do what you want to do and what you feel called to do, and you can actually have a life.
I love that. And I do, as a woman myself, I absolutely hear what you're saying in terms of the things that the way that we are trained as physicians, the way that we manifest being a physician is definitely unique. And I think that the challenges of being a DPC woman and a physician, there are things that other people who are not women might not understand. And so I definitely would say that that is something very valid. So if you are ever feeling, and I'm speaking to the listeners here because you and I, Dr. Bernard, have felt this, but if you are ever feeling like you are being put down or you are not being heard, it's like the Band-Aid feeling, like rip that Band-Aid off, take that experience, learn from it, and go elsewhere to talk like groups like DPC Women.
I think what I hear you saying is that women must feel free to speak their truth, and your reality is the reality. And if someone says to you, but that's not true, women don't have it this way, women don't have it that way, you're the woman and you're the one experiencing this. So therefore, it is true. And I've had some recent instances where I've shared some data regarding what women physicians face. Studies are still showing horrific findings regarding sexual harassment, not only by patients, but by fellow physicians, which is just appalling. We're seeing, of course, studies show over and over again that patients talk more to women physicians. They're more demanding towards women physicians. Patients and staff send women physicians more inbox tasks. I mean, these are realities, and I'm told that that's not true. And I don't know how to convince someone if they don't want to be convinced, but I guess I don't really need to because I know it to be the reality, and the women listening, that may be your reality, it may not be. But regardless, it is okay to own what we're experiencing, and it is okay to push back when someone says to you that's not true. You can agree to disagree. This is my reality, and I don't think you should let someone else tell you what your truth is.
And I definitely would say as the DPC community grows, you can find your people. I am so grateful to have found my people in this community, as I'm sure you are. The way that DPC is going, like literally there are people with kids, no kids, just recently married, married for 12 years, like all over the place. People are opening 26 years after they've practiced in private practice or corporations. Literally, there is somebody out there who can relate to you. So I definitely echo that in regards to you're not alone. And if you don't know who those people are, just keep asking, find connections.
Yeah, and
So
realize that we're always growing, we're always changing. I'm coming to you now at the age of 50. When I was 30, I was not this brave. I could not speak out. I could not at that time start a practice. I've also done plenty of therapy to help me get to the point where I did find my voice and I can speak out without fear. So just, I guess I would say to be kind to yourself wherever you are, talk to other people, find your tribe. I think that is such good advice. And I'm a big believer in therapy. Some people prefer to go with coaching. I think a good psychologist is worth their weight in gold to kind of help you get into your own head and to understand where some of these thoughts and anxieties and feelings are coming from, and to help you learn how to find a healthy way to deal with them so that you can be not only the best doctor you can be, but to be the best person you can be.
amazing. And just in that space, you are also a member of the DPC Alliance board. So can you talk about how that even came to be and why did you choose to pursue that?
Well, there's a couple reasons. First, I, of course, give the credit to Clodagh Ryan, who nominated me for the board, and thanks to the Alliance members who voted for me to serve on the board. But the first reason agreed to do it was that I wanted to do something a little more positive and happy, because I'd been serving on the board of Physicians for Patient Protection for some years now, and it just feels like banging your head in the wall, and that a lot of times it's doom and gloom as we fight this legislative scope of practice year after year. So I still am very involved with that, but I wanted to do something a little more positive. And of course, I also see that link with physician-led care, because I think in the DPC space, I do hear some people in certain ends of the political spectrum, especially those that have the more libertarian leanings, that kind of have this idea of, well, let's just let the market decide, and that a rising tide lifts all boats, and that it's okay to encourage NPs and PAs to have their own practice. Unfortunately, I think what they're missing there, and I'm also a free market person, and I have some libertarian leanings myself, but what they're missing is the fact that the market doesn't really know or understand, and ultimately these are patient lives. So if we're going to allow the market to decide, the market needs to have complete informed consent, and they need to know and understand the differences in training and education of those different clinicians. So I wanted to be part of the DPC Alliance to just make sure that I was at least sharing my feelings on that. And if I have any influence on the community, I wanted to be able to do that. I also think having more women in leadership positions, because we know that women just often don't have the time or the energy to do it. I don't have kids. I just have 2 dogs. I do have a husband who would very much prefer that I don't do anything except hang out and watch TV with him. But he is also very encouraging of what I want to do. He understands that I got to do what I got to do because I'm called to do it. So that's why I started getting involved. It's my first year serving on the board. I think there are some incredible people doing some really incredible work. And I was just so excited at the DPC Alliance meeting, working at the DPC Alliance booth, and seeing so many people come up and look to the Alliance as a place to get information, to find mentorship, to find special pricing, to keep their prices low. So I'm really excited about what the Alliance is doing, and I'm looking forward to continuing working with them to just offer more to our community.
And especially if you're new to the podcast, dpcalliance.org is where you want to go. And one of the things that is not necessarily known by everybody, just hearing about the Alliance, is the malpractice benefits that it brings to its members. Dr. Neil Douglas was instrumental in developing the connection that you guys have now. But for people who are looking for malpractice as they go into their DPC journey, that is definitely another value that the DPC Alliance brings. So definitely check that out. Thank you so much, Dr. Bernard, for sharing today your story. It's been incredible to have you.
Thank you so much for taking the time and interviewing me, and all the work that you're doing to spread the word about direct primary care, because honestly, it's life-changing for physicians. It's really the best thing for patients, and you're giving them the hope and the encouragement that they can do this too. So thank you for all the work you're doing.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Maryal Concepcion.